Okay, so for those of you who are in with us now, I just want to take a moment to welcome all of you to today's webinar. My name is Lindsay Caldflesh. I'm a knowledge broker with Gambling Research Exchange Ontario. You will notice that your mics have been muted upon entry to the WebEx platform, and that's intentional to cut down on background noise during the presentation. The presenter will stop for questions at the end of the presentation. We'll have some time dedicated for conversation and questions then. But during the presentation, if you have a burning question, there is a hand raise function in the WebEx platform that will allow you to virtually raise your hand so that I can see that you'd like to ask a question and I can unmute your mic when there's a sort of a logical break to do that. If you do not have a microphone that you can use and you're not calling in through your phone, you can send a question via the Q&A function or via the chat function, and I will do my best to moderate that throughout the session as well. If you do have questions that you are able to hold until the end of the presentation, that is preferable. And I think that that's it in terms of housekeeping items. So I will now introduce our presenter. Jess Voll is my colleague and is also a knowledge broker of evaluation here at Gambling Research Exchange Ontario. Prior to joining us at GRIO, Jess worked in the healthcare field for government-funded organizations in health promotion, quality improvement, and evaluation capacities. Jess holds a Master of Public Health from Lakehead University, a Diploma in Health Services and Policy Research, and a Certificate in Evaluation through the University of Victoria. Most recently, Jess was designated a credentialed evaluator through the Canadian Evaluation Society. As someone with a public health background, Jess has been naturally enthusiastic about stimulating dialogue on adopting a public health perspective to reducing harms from gambling. And without further ado, I will introduce Jess. Okay. Go ahead, Jess.
You can't hear me or I am cutting out.
We can hear you. We got you.
Okay. Please let me know. As Lindsay mentioned, I have a public health background, and this has almost been a bit of a personal project for me. I've been quite excited to take on this new program at GRIO, in which we are looking at public health, taking a public health approach to gambling. This two-part webinar series is designed to really delve into what is a public health approach to gambling. You know, it sounds really good, and it sounds like something that we can all get behind, but kind of what are the nitty-gritty pieces of what that actually looks like? And in the two-part series, today we'll be focusing more on the theory, so looking at elements of a public health approach that we need to understand in order to apply them to how to reduce gambling harm. And in the second element, the second part, which will be in November, we'll delve more into the practice piece. And that will be more of the examples of what we have seen done to date, internationally, nationally, locally, where individuals and organizations are indeed applying a public health approach. The manner in which social issues are framed directly impacts on public policy debates. I wanted to start with that statement because I really feel like it brings home the issue that we have here today. And that is the way in which we view gambling harms as being something that's more individual focused or community and public health focused is going to really change how we work to intervene and prevent harms from occurring. A public health approach really rests on shared responsibility for population health, from individuals and community groups to businesses, corporations, and governments at all levels. Something that I'm going to keep reiterating throughout this conversation is that the public health approach is really more than just the individual behavior. We're really looking at all the different factors that influence someone's harm from gambling. And we're also looking at systemic inequities that contribute to a disproportionate experience of harms or benefits. So when we're talking about a public health approach, there are three main levers that we can look at to understand the areas of action. And those are harm minimization, health promotion, and political determinants. If you work in public health or even just in the mental health and addictions field, I'm sure you're well acquainted with the term harm minimization, sometimes harm reduction or preventing harm prevention. In the context of gambling, we're talking about minimizing the risk associated with gambling without negatively disturbing those who gamble recreationally. So essentially, how can we allow this, continue to allow this form of leisure to exist, but still minimize harm for those who may experience it? These strategies mostly modify the gambling environment, product, or consumer to reduce harm. What's really important to understand about the harm minimization lever is that it's emphasizing that the product is the underlying source of harms and not the individual. And at first, that sounds pretty great to recognize that the product itself has inherent harm. The problem is that if you continue to take that logic further, it also implies that any individual can interact with the product and not experience harms if they do so in a certain manner. So if they were to set limits and budgets and interact with the game in a way that was known to be safer, then that individual should be free of experiencing harm. Well, we can't talk about health promotion without talking about the Ottawa Charter for Health Promotion. So the health promotion is really really gets to how we can empower individuals to live and achieve healthier lives. There are 5 action areas in the Charter, and I'm only going to speak to 2 in more detail. I do want to pause for a minute here and look at the personal skills piece. So of these 5 action areas, only 1 is really focused on more individual level behavior. The other 4 that make up this kind of list or suite of health promotion opportunities and action areas are not individual focused. They're more on the environment, community, system, and policy. So building a healthy public policy, this can include things from legislation, taxation, organizational change. It's really coordinating health and social policies to improve health equity. And what we're really talking about here is how can we put systems in place that make the healthier choice or experiencing the greatest health possible the default option. A great example of this in public health is the work around tobacco. So you can think even in Ontario how many restrictions there are on where you can smoke. And by virtue of making it more difficult to smoke, we actually deter people from smoking. And we decrease the amount of people that are exposed to secondhand smoke. Now this doesn't replace individual level education and messaging around why people should quit smoking, how they should do it, the dangers of smoking, etc. It's just really making an environment that's conducive to that. Sort of in the same line, creating a supportive environment. These state that health cannot be separated from societal goals. So we cannot strive to reduce harm from gambling without pursuing other goals like reducing poverty or homelessness and things like that. Likewise, there's a strong relationship between health and environment, both physical and social. And so work and leisure should support this health. So we really need to understand how do factors in someone's environment, the physical and social, their workplace, how do those impede or prevent someone from experiencing the best health possible? Okay? But ethical gambling goes one step further. Ethical gambling states that it is the moral obligation of companies and governments to create environments that will reduce gambling harm. Moreover, this line of thinking says that gambling should be an economic activity last and emphasis on preventing harm first. So first, we need to look at the conditions that gambling can exist in that will be as safe as possible before scaling it up, versus creating all these different opportunities to gamble and then saying, oh, now how can we make them safer? There are a couple models for framing gambling harm that we can look at. The first is the medical model. It's kind of a black and white categorization, very much a discrete disease model. So it implies that only problem gamblers experience harm. So you're either a problem gambler or you're not, and that you experience harm or you don't. And it's very much focused on the individual. And it does not look at the broader social terms of health or the more pervasive social norms. or social harms. The consumer and self-responsibility model, it is very prevalent in many of the responsible gambling initiatives we see today. And it essentially looks at gambling as a purely service product or consumer good. It's offered in the marketplace, and it's selected by consumers in order to maximize their utility. It also assumes that consumers are informed, rational agents with access to all the information and options they need. And it's important to note here that there's very much a libertarian sort of philosophy here, a free market approach, basically that we should be a little more hands-off as long as we give consumers the information they need and are deserving of to reduce their harm from gambling. That's kind of where the government or other agencies have to kind of draw the line in terms of what other harm mitigation strategies we can put into place. It really is emphasizing the freedom and responsibility of the individual to make effective consumer decisions. If you're in the gambling world, you would have probably heard about the Reno model. But for those of you who are less familiar, Blazinski et al. In 2004, and later iterations as well, worked to call for a collaboration of key stakeholders to reduce harms from gambling using evidence-based principles and regular evaluation. This really adopted a consumer model. It was basically stating that safe levels of gambling participation are possible, and gambling provides a level of recreation, social, and economic benefit to individuals in the community. And it really did have the elements of the self-responsibility model we saw before, where that individuals need to be informed and they have a right to have access to that information. But that again was kind of where that model stopped. So when we look at some of the criticisms of the model, Hancock and Smith were some of the more vocal in discussing the model. They felt that there was an overemphasis of individual level responsibility and informed choice, which again goes back to that libertarian ideology. They thought it was faulty to assume that responsible gambling stakeholders all have similar goals. So by bringing together all these stakeholders around the table, do they all want the same things? And when we talked earlier about the tension between industry and health advocates and even the different roles within government, you can understand how, although all the stakeholders may want to work together to reduce harm, what that looks like and how that might happen may look different. And ultimately, they felt that this model just allowed for business as usual, if not much action to take place. They really iterated a skepticism over self-regulation of industry. One of the first examples of a public health approach to reducing harm from gambling we saw was from Korn and Schaefer in 1999. And if you're in the public health world, you will be familiar with the infectious disease model. And that's kind of how they conceptualize trying to have the conversation around how gambling occurs with, due to factors beyond just the individual. So in this example, we have the host. That's the individual that chooses to gamble and may have genetic and behavioral predispositions that influence risk and resilience factors. We have the vector, so the means by which they could do that. And originally, Korn and Schaefer just had money in their diagram, but we've since updated that to include points, credit, and time, which of course is in line with all the different ways in which we can gamble today. And then finally, the agent. And the agent are all the different opportunities in terms of games. So casinos, scratch tickets, sports lotteries, online betting, you name it. And then circling this is the greater environment. That's also the gambling environment, the cultural, social, and political factors, and considerations around proximity and access to gambling. So all these things together influence how an individual will experience harms and what those harms may look like. Now, this model was a great sort of first step in helping us kind of reconceptualize that there's more than just the individual at play here in terms of whether they can control their behavior to gamble in a healthy way. but it really does still talk about the individual. And as we get to later parts in the presentation, we're going to talk about how we've moved beyond the individual and looking at it from more of a population level. And similarly, they stated that the goals of a public health approach were to prevent gambling-related problems in groups at risk of addiction, to promote informed and balanced attitudes and behaviors towards gambling and gamblers, and to protect vulnerable groups from gambling-related harm. If you've been on our website in the last little while, you may have seen this diagram. This is our gambling harms mind map. And I'm just pulling this up because I want to give you a quick visual of what we know today are all the different factors that influence how someone will experience harm and in what ways and who. So we have factors like ethnicity, age, mental health, substance use and addiction, living conditions, education, socioeconomic status, and health behaviors and risk factors. Some of those health behaviors are those individual personal factors as mentioned in the charter. Those are the areas that we would target an individual to, again, set budgets or whatever other kind of positive coping skills they needed. But you can really see here that there's so much beyond the individual's control and their behavior that influences their harm. And the reason that this is so important, and I keep reiterating it throughout, is two parts. One, what we know today in terms of the complexity of what experiences harms an individual. It's not very compatible with a primarily responsible gambling approach. So the responsible gambling pieces are great. We absolutely still need that individual level behavior education to help individuals make better choices and empower them in their communities. We also need to understand that there are so many pieces, some of these what we call social determinants of health or comorbid health conditions beyond their control that are influencing their harm. And actually that leads me to my next diagram, which I hope helps kind of clarify this point. A lot of the work being done in gambling to reduce harm is very much at that responsible gambling level with individual focused health promotion. And that work is great and it's important. And that work is really looking at identifying at-risk individuals for moderate to high risk of problem gambling and following a harm minimization approach. Now that harm minimization approach isn't incompatible with a public health approach. It definitely overlaps and it's important. But if we're truly going to take a public health approach, we've got to look at the big ring here, the population level prevention. This is when we're adopting a public health approach that considers how factors outside the gambler's control influences their likelihood of experiencing harms. So we will still work with individuals to empower them to make better choices and to understand the odds and coping skills, etc. But that population level prevention piece is kind of getting back to some of those conducive environments and policy changes that I mentioned earlier in the charter. And of course, we still have the traditional clinical treatment and prevention. We need that. That's still something that happens. But hopefully we can start to do more of our work in this big circle, the population level prevention. And then if we do, we could expect that maybe the next two rings become even smaller. As our understanding of what a public health approach to gambling has evolved, there has been a really great question, which is, what are harms from gambling? What do we mean when we say that? And that's actually been reiterated in the literature for at least probably a decade and a half. And Langham and all iterated into 2016 that that's a very big barrier to adopting a public health approach to gambling. We're not using a consistent definition of harm, and we also have an inadequate understanding of the breadth and experience of harm. Moreover, we have a lack of appropriate methods to measure harm. We're often using screening and diagnostic tools as a proxy, which conflate behavior with harm. So we have one of the most popular gambling diagnostic tools is the Problem Gambling Severity Index. This is, if you're not familiar with it, it's similar to your anxiety or depression scales, where you will fill out the scale, get a score, and you'll be in one of X categories. The argument here is that it is really only capturing behavior. So do you do this or do you do that? Doesn't capture harm. So there can be people that don't participate in the behavior but still experience harm from gambling. And moreover, it also doesn't look at others beyond the individual. So I might not be the gambler, it might be my husband, and how can someone measure the harms I experience in our relationship and our family and maybe even our community as a result. There actually is some really exciting work that's happening in that area. So hopefully that's something that we'll see on the horizon soon, that we will have some more clearly defined ways to, at least in Ontario. So Langham and all proposed a definition of harm, which I quite like, and it is any initial or exacerbated adverse consequence due to an engagement with gambling that leads to a detriment to the health and well-being of an individual, family unit, community, or population. So really, again, moving beyond those behaviors, that kind of almost, again, more of a black and white approach to understanding that harm can be experienced in many ways. And the 7 harms that they have listed here that they categorized into are financial, relationship, emotional, detriments to health, cultural harm, reduced performance at work or study, and criminal activity. And moreover, they felt that these harms could even be further classified by those that are general, so they're a harm that someone may experience at any time, crisis, so they can experience an element of this harm or a manifestation of this harm in a crisis spot in their life. And then finally, legacy. So those would be the kind of harms that, say financial harms, if you were to declare bankruptcy, the legacy there is that for 7 years after, or depending on where you live, you wouldn't be able to obtain credit. So things that follow you throughout, even though the issue was resolved. And of course, these harms can occur across your life course, and they can also be generational and have intergenerational harm, as some of those pieces are passed down to the next level in the community. Okay, so if we're going to refocus away from problem gambling, where does that lead us? Well, most of the harms occur from low-risk gamblers simply because there are more of them. And that means that we're assuming that interventions that focus on low-risk populations have the potential to reduce a much greater burden of harm and reach a much greater number of individuals than focusing on high-risk individuals. So it's not to say that we shouldn't still provide treatment services to problem gamblers. Absolutely we should. But the public health approach should really be looking way upstream, so low-risk gamblers or even people who are not gambling yet, and their community and family members. Of course, this does lead to the prevention paradox, which is that individuals that are affected by the intervention often don't benefit from it and may even be inconvenienced by it. So for example, if you think about maybe rules in casinos around where and when you can have alcohol, if I don't have a problem with gambling or alcohol, but I need to follow that rule, maybe my experience there is altered negatively. But by putting that in place, we're helping other people. And I would say really that prevention paradox, that helping the focusing on the lower risk upstream sort of approach is really fundamental to the public health approach. This is a diagram of kind of all the pieces of the pie for a public health approach. I don't have time to talk about each of them in detail, but I do want to touch on a couple and explain how they link to reducing harm from gambling. So first of all, what does it mean to focus on the health of populations? It means the collection and analysis of population health data for planning, implementation, and evaluation. So really we're asking, how healthy is a population and what is happening to their health over time? Who is healthy and who is not? And what can be learned from health data trends to help prepare for the future? So in our case, we might be asking, to what extent is the population experiencing harms from gambling, and in what forms? Which groups are experiencing a disproportionate amount of harm? A population health approach considers health status and health status inequities of the population as a whole, as well as groups within it. So even though we start by looking at the whole, we do tend to narrow down and understand, are there different parts of the population that are being disproportionately advantaged? We think about upstream investment, multiple interventions, and collaborations across sectors. Well, upstream, we're really looking at addressing the root causes, which is often where looking at systemic inequities comes in, which of course are difficult to change and require greater social, economic, and political change. Likewise, though, multiple strategies are needed to be sensitive to unique considerations across the lifespan. We have to meet people where they live, work, and play. And it also means balancing individual level personal practice and education with addressing factors such as poverty, which are outside their control. So let me give you examples for here to kind of illustrate this. So we know that those that participate in criminal behavior appear to be more at risk for gambling harm. And a recent study in 2018 actually found that a gambling disorder group of inmates showed significantly lower educational attainment than inmates that were not gamblers. Cocaine abuse and failure to graduate elementary and middle school in the expected time were also independently associated with that disorder. So then we might ask, well, what is contributing to their likelihood of failing to graduate? Does it have to do with familial factors? If so, how do we work with the family and adolescents at this age to reduce the likelihood of dropping out? And this overlaps with the need for multiple interventions and collaborations across sectors, because in this example, we might want to investigate collaborations with the education sector to develop protective factors and capacities in families via school. So this is a little wordle here, and what you're looking at are the determinants of health. The determinants of health are the broad range of personal, social, economic, and environmental factors that determine individual and population health. We often speak about the social determinants of health, and these are a specific group of these factors within the broader determinants of health, and they focus on an individual's place in society, such as income, education, or employment, and also experiences of discrimination, historical trauma for certain groups such as Indigenous people. So understanding the determinants of health, and in particular the social determinants of health, is really what kind of underpins that population health approach. Because by working in these areas, we tend to work more upstream and we work across the population and not at the individual level. Health inequity refers to health inequalities that are unfair or unjust and unmodifiable, and these are also central to a public health approach. So an example of that could be if there are health promotion resources that vary by geographic region, well, that is an unfair, unjust, and unmodifiable health inequality. So we're looking to reduce those basically so that all members of the population have access to have the services and care and education they need to achieve the best health possible. Well, we've gone through a lot today, so I'm just going to recap with a couple of key messages before we get into discussion. The first is that responsible gambling initiatives can be an important part of a public health approach, but they're only a small piece. So remember, any kind of work that we're doing that is at point of play, where we're trying to educate individuals, and whether that's online or it's in a casino or it's at a convenience store, any of that kind of messaging that they see, that's great, and that should be there, and that contributes to having the right to access that information, but it's just a piece of the puzzle in terms of how we reduce harm from gambling. A public health approach moves away from an overemphasis on individual behavior and responsibility, acknowledges the role that determinants of health, comorbid conditions, and the social and built environment play. So really we're saying that there are so many things that are beyond the individual's level of control that are going to influence whether they experience harm, which is why we can't only rely on individual behavior strategies to reliably reduce or prevent harm, because we know there's so many other things that will influence that. It also means reconceptualizing harm, so the type, who experiences them, when, severity, and facilitates both an upstream approach and the destigmatization of gambling harm. And that's actually something we didn't talk a lot about, but there have been some arguments made that focusing on responsible gambling or problem gambling at very individual level behavior can be stigmatizing, because it's essentially saying that if the individual took different courses of action or behaved differently, they would be able to reduce harm, and that can contribute to stigma. And we also know that stigma prevents individuals from receiving harm. So a bit of a negative cycle can start there. We have to acknowledge that there's a complex role of government in both preventing and facilitating gambling harm. So it's not a good thing or a bad thing. It's just understanding kind of the lay of the land and really thinking about how we can engage each other meaningfully and have dialogue where we're all working towards collective goals. And finally, implementing system-level changes that make good health the default, perhaps through policy changes, protect vulnerable groups, and address underlying systemic issues that perpetuate gambling harm are fundamental to a public health approach. Wow, so that was a lot of information today. So before I open it for questions, I want to keep the conversation going even after this webinar. We're going to have a part 2 to this webinar in November. That's when we're going to be dealing more with the practice piece and looking at examples, many of them internationally, about areas that have adopted a public health approach to gambling, to give you some more tangible ideas. And if you want to learn more about this topic or participate in this conversation more generally, please head over to our website. If you go to our website, we have under our programs, Gambling from a Public Health Perspective, and there are lots of resources in there that should help you get the information you need. We also have a BET funding program in which we work with public health professionals to provide them with funding and knowledge broker support to do system-level work to reduce harm from gambling. So if you're in Ontario, you're eligible for that, as long as you're a not-for-profit. And we have a call actually opening up very soon on October 1st for a new round of funding, so stay tuned. And finally, I'd encourage you to join our community of practice. So if you're interested in networking with other public health professionals, to kind of learn what they're doing, share challenges, that's a great place to be. And at our meetings, we have a regular guest speaker. So actually, we just had a community of practice meeting on Monday, and we had Nicole Wilk from Youth Gambling Awareness Program out of the YMCA do a presentation on the blurring lines between gaming and gambling in youth, which was just fantastic. So it's also a great opportunity for you to get some more information that might be meaningful to you. So I think without further ado, I will wrap it up, and Lindsay, you can let me know if there's any questions.
Thank you so much, Jess. Jess, can you just confirm the URL to our public health arm of our GRIO site?
Yeah, I have to pull it up.
Yeah, we can send it out. We can send it out in the chat section. So for all of you who are joined in right now, and you got the audience can't see, but there are 34 attendees in the space right now. We'll send out a follow-up email with the link to the public health site, maybe some of the things that Jess spoke about, and also the link to the recording of the video. So, like I mentioned at the beginning, but some of you have joined since then, this is an opportunity for you to ask any questions for Jess, and also if you have a microphone, you can do that by raising your hand, and I will unmute you. I see one hand raised potentially right now. And if you do not have a microphone that you can speak through and you're not connected through your phone, you're welcome to send your question via the chat function or the Q&A function, and I can moderate to the best of my ability. So I'm going to start with Charles here. Charles, I've unmuted you. You can ask a question. No? Maybe not. Okay, I'm muting you again, Charles. Do we have any questions in the audience for Jess about her presentation? Oh, I have hand raised. Let me just flip to my Q&A section here. Oh, Charles was wondering what the web address was. So Charles, we can definitely follow up with you about that via email. Oh, okay, I have it up in front of me. It's grio.ca/en/public health. But we can also send that out. And I see Eva's got her hand raised. Eva, can you connect with your microphone? Maybe not. Oh, here we go. So Eva sent me a message via the chat function. What do you think the role of researchers is in the context of a public health approach? Jess, that's for you.
Yeah, that's good. That's a weighty question. I guess I would say that the more research that can be done in this area about the efficacy of a public health approach and looking at models that have exist would play certainly a big part. I don't think, to my knowledge, there's not a really wide breadth of research done on this area, so there's not a lot to pull from. And I guess just trying to find a way that we can complement the work that we do need to do around researching what attributes of a game make it more addictive and not. So how do we balance both research around individual level factors and game features and other kinds of opportunity to gamble, like those features and elements, but also looking at how we can work more on a system. And I kind of wonder if there's an opportunity for gambling researchers specifically who have a lot of expertise in that area to be doing some partnerships with more public health leaning researchers that have more of that expertise so that we can be learning from each other. And I think actually as I'm thinking that through, that would be the take home for me is the public health approach is about working across other sectors and with others that are outside of our expertise. So even from our research, we should start there. So the research that we're doing should demonstrate sectoral collaboration with stakeholders.
Thanks, Jess. We have another question first from Brian. And the question is, what are some alternatives towards naming a program which provides services to those who have issues with gambling without being stigmatizing, naming it something that would be stigmatizing? So an example would be the problem gambling services that are offered potentially by Brian's organization, which can be a stigmatizing way of phrasing that. Do you have any suggestions around alternatives?
Well, I do agree that the use of problem gambler could definitely be construed as stigmatizing. I think you'd want to, I guess it's twofold. It's one, sure, it's the title that you use, but then it's also, how that service that you're offering, how it frames the individual's level of responsibility and also explains to them the things that are beyond their control. So I don't know if I necessarily, I'll have to think about that. I don't know if I necessarily have, a kind of a catchword to replace problem gambling that would be also still be meaningful and kind of like bite-sized and accessible to the individuals that you wanted to capture. However, I would say from a knowledge translation point of view, doing some knowledge user engagement around that, so actually working with people that do have problem gambling or just gambling harm and talking to them about how they feel and whether that term is stigmatizing or not, and if they had a different way of explaining it that they think other people would resonate with, that would definitely be one area to start. And then beyond that, like I said, it's also when you have them in your door, how are you explaining to them what is beyond their control, and while still working on what is in their control. So I mean, I think that balanced approach of working with them to put plans in place and change their behavior is important, and certainly that's why those services exist. But if you are also explaining to them that there are things beyond the control, and if you are referring them to other services that you know that they would benefit from, that may act on the social determinants of health. So if you know that they are homeless, or they have low income, or they have cultural barriers, or whatever, if you're also addressing the problem that way, I think that's another way of sort of destigmatizing the whole experience, because you're kind of getting to the root of the issue and you're trying to resolve some of those health inequities.
Thanks. And Brian says that that's great feedback. He thinks asking the clients what would be non-stigmatizing, along with empowering them to understand what is in their control versus what is out of their control, is a good idea. So thank you, he says. And Susan wonders if there's any work that you know of that's happening at the provincial level to restrict advertising of gambling to an adult audience.
Not that I'm aware of. I could certainly look into that. And if Susan has any more like specific examples of types of advertisements or elements of advertisements, maybe she can send you a message, Lindsay, and then we can definitely look into that and follow up with her.
Awesome. So I don't see any other questions coming in via the chat or Q&A function, and I don't see any hand raised currently. So Jess, do you have any final words that you'd like to say before we wrap up?
I guess my only final words would be to consider thinking about how you can generate this discussion in your organization and what the impact might be. Any kind of I don't really want to call it a movement, but anytime you have what may be a paradigm shift, like in this case, and we're moving away from what is more comfortable and known to what is a little less comfortable and definitely more unknown, we really need to be having a lot of conversations with those that might be involved to kind of get the manpower and enthusiasm to make those changes happen. So, it could be as simple as going back to your organization and almost doing like a little bit of an inventory. Where do your activities fall? Are they mostly harm minimization? Are they mostly treatment? And if they are harm minimization or treatment, are there opportunities for you to adopt elements of a public health approach within those? And it could be everything from services and programs you offer to partnerships and collaborations you have with other organizations, or maybe it's just even the language we use and how we talk about the problem, who we talk to about the problem, and why we're talking about it.
And so for the people who are listening who are looking to sort of be a part of this change and this shift and this movement, how can they connect with us to make that happen? What's their best point of contact?
Yeah, I would love to talk to anyone at all who's listening and is interested in chatting about it further. They can email me at jeff@grio.ca, and Lindsay can write that in the chat function as well. And just kind of on that line, and as a plug for our program. So if it's not clear, if you didn't know, or if it wasn't clear, we are a ministry-funded not-for-profit, but we run this program, and we're really keen to collaborate across Ontario, across the country. We do have funding opportunities if you're in Ontario. We would love to be collaborating and extending our resources. We also have knowledge brokering activities. So if you are in Ontario and you have a need to gather evidence around something related to helping you frame gambling as a public health issue, please come to us. We've got a whole lovely database of our evidence center with lots of peer-reviewed research in there, and some librarians on staff to help us find exactly what you're looking for. We offer a lot of services to help you get the best available evidence, and yeah, just a lot is possible. We're really creative and open to collaborating. So please just email me, and I would be happy to continue a conversation offline about how maybe we can support your organization.
Wonderful. Well, thank you so much to Jess and to all of you who attended the webinar today. And again, I've posted Jess's contact information in the chat, so if you'd like to do any further follow-up with questions or ideas for collaboration or any other further ideas or thoughts, please connect with Jess via email. Thanks, everyone.
Thank you.